Hey everybody, we are live from Move Men's headquarters in Seattle. This is Dr. Sam Watkins. Welcome to our ACL Community. This platform was created by the Move Men Rehab and Performance team to educate, empower, and improve the outcomes of all ACLers. And with me today I have...
Hi everybody, I'm Dr. Mica, also physical therapist, strength and conditioning coach, ACL Rehab specialist, and an ACLer myself. So we are going to answer some frequently asked questions today. Basically, some people have asked us a bunch of questions, but we also want to touch base on questions we get often in the rehab process from people who are about to start their journey or in their journeys at some point. So we're going to go over some things like leg extensions, their procedure, things like that. And then if you do have any other questions, feel free to let us know in the chat and we'll get to them.
Yeah, that sounds good. I mean, a lot of these questions, like Mica said, are ones that we've been asked by people from the community, and we'll answer them on the feed, so maybe you'll see some of these that have been touched on, but we just want to make sure that we're going into some more detail so you guys are getting the answers to your questions. That's really the gist there, though.
Yeah.
We're going to jump into it, Mica?
Yeah, let's get into it.
All right. First question we've got here is about leg extensions, right? Really common question. I feel like the leg extension is a divisive exercise at this point, but really good research for it. And are leg extensions safe early in ACL rehab, Mica?
100%. I think, I think it's hard because a lot of protocols still also say like no leg extensions or open kinetic chain things for 6 weeks, 12 weeks, whatever it may be. And I don't think that fits with like the evidence that we have in the rehab world, which I think that needs to change. There wasn't enough information. It seemed like it was based on theory back in the day when they made that statement, but we have a lot of really good evidence behind it. And, I think, will somebody be able to right off the bat, 2 weeks into their rehab, be able to do 50-pound leg extension? Probably not. I think, there's a lot of safe ways to do things and making sure that we're loading and isolating the quad to the best of our ability and within the person's tolerance. Yeah, I don't know. Your thoughts?
Yeah, I agree. I mean, you can't overdo it.
Yeah.
Right? I mean, the idea behind this question and the controversy around it is that a leg extension does put stress on the ACL, but shocker, so does doing anything with your knee, right?
Yeah.
And there are some studies that show that walking is more stress on the ACL than I believe it was a 12 rep max.
Yeah.
So if you're doing 12 reps on that leg extension as hard as you possibly could and couldn't do one more rep, that still is less stress than just walking.
Yeah.
And so that's not to say that you should go do a 12 rep max 2 weeks into your ACL rehab, because there is some strain. Your knee's not going to like it.
It's not going to like it, yeah.
But it's not because it's going to increase laxity.
Yeah.
And a lot of long-term studies have shown that people that incorporate leg extensions into their program throughout end up having better quad strength and no increased laxity. So the idea of things not being functional and also increasing laxity are kind of thrown out the window there.
Yeah, exactly.
So
I think so, yeah.
How do you like to start people off with leg extension movements early on?
I think it really depends. I think it depends on a lot of things, but isometrics are really a solid way to do it. It all depends on just the range of motion that's available, pain tolerance, all of those things, but you combine it with BFR and it's just a solid choice. For me, for example, as going through my own injury, like I didn't have available range, so I had to modify what I could do, and there was just a lot of things that I had to work with, but find ways to load it. So I think isometrics early on are a really good option. Of course, doing like some short arc quads, long arc quads, something like that to really just see what they're able to handle. And some, you pair it with BFR and that's enough for their leg to get fatigued early on.
Unweighted, you mean, right?
Unweighted, yeah, unweighted for sure. And then eventually build up to the point where they're able to. But yeah, that's usually how I start them off. Yeah.
What about, it sounds like early on you stick to more leg extension isometrics, and maybe like very lightweight or unweighted with blood flow restriction, which I agree. Both of those is how I like to look at things too. Like load up the quad in a 70 or 90 degree position if they have that range, and that is very minimal stress on the ACL. And also get the quad working. And then with BFR, you can do more like unweighted or very lightweight, and early on it's definitely enough to get people tired. But what's your thought on when you like to start loading people heavy-ish through a full range?
Oh, that's a loaded question. I think, honestly, for at least like the first 4 to 6 weeks, I usually see, at least for the first 4, I'm trying to really hit heavy on the isometrics, build them up to like 45 seconds, get them really going that way and incorporating some movement that way. But then I eventually do bring in some load. It's not 25 pounds, it's not 45 pounds. It's like we're going for a higher volume with that and then seeing what the knee's response is. And then, it's hard to say because it's nice to have a plan, but the biggest thing is like sometimes the knee doesn't like that plan and you have to like switch things up quite a bit. So, I feel like really it depends on the person, but between weeks 6 and 12, like sometimes you can start doing a really solid, heavier program for leg extension, and the first 4 to 6 weeks, you're just trying to get the knee to calm down anyway. So, I think that's usually what I go for. Like in terms of sometimes with the range available, I will try to, there is evidence behind, it's okay to go from 90 to 0, of course, with a leg extension, but sometimes somebody's knee can't get into that 0 degree extension. So, I kind of dab with that a little bit too, and just see how somebody responds to it.
Yeah, no, it makes sense. It all is, it's very individual. Right. And we need to follow guidelines based on tissue healing and based on what this new ACL, this immature graft can handle. But with the leg extension, there are some precautions you need to take, but it really is, in my opinion, more about what is their knee able to tolerate. Right.
For sure.
Sounds like that's.
I think, the biggest theme of it all. Perfectly safe to do at the end of the day. Honestly, probably more dangerous for somebody not to do it. Because this is one thing that we do see in terms of outcomes in ACL rehab. And this is, there's no amount of lunges, squats, or anything that are really going to isolate the quad any better than a leg extension. And I think that's what people need to understand is like, we need to go out with the old and really in with the new to just really make sure that we're doing everything we can.
Yeah, but it's not functional, Mica.
I know, but it's like
it's not fun. It doesn't look exactly like the sport that I'm playing. Like, why would I waste my time? We hear that a lot. That's just it's the argument we need to fight against. Building strength so you can manage the forces of your sport and activity is functional.
Yeah, for sure.
Doing something with really light weight because it looks like your sport is not.
Yeah,
so,
absolutely.
So newsflash, leg extensions are safe as long as they perform appropriately early in ACL rehab. And then let's move on there from the leg extension because that could literally be an entire topic. Knee sounds after surgery. So is it normal for your knee to make noise after surgery? Mica, do you have any noises? Your knee talking to you?
Oh yeah. This is very, very normal. I tell people right off the bat, like, just because you don't know when these noises will start popping up. I think like mine started maybe around week 2, week 3. You'll get some crunchies, you'll get some Rice Krispie sounds, you'll get some squeaks, sounds like you need to put some WD-40 in there, and it's totally normal. It's not anything to be concerned about regarding like your sutures, anything regarding about the hardware inside, none of that stuff. It's very unlikely, very, very rare that you're going to have an issue with your hardware, but they're very normal. The biggest thing, as long as they're not painful, I think that's the biggest thing to take home is expect some noise, expect some crunchies, and as long as it's not painful, you're okay. Yeah, I think literally mine was literally squeaking like a mouse the other day. So you just like go back and forth and it squeaks and that's it.
Yeah.
Yeah.
You inject some WD-40 in there?
That's right.
That's the answer, right?
That's the answer.
Yeah.
Dad, please don't do that. Don't do that.
Do not put any foreign chemicals into your knee.
Yeah.
Please, yeah. No, that sounds
Yeah.
That sounds about right. And I get that people are nervous about new noises
Yeah.
after surgery. I mean, there's nerves about any awkward step they might take, right?
Yeah.
And especially early on.
Oh, yeah.
But your knee is going through a healing process here, and there's a lot of swelling and inflammation. And as long as it's not painful,
Yeah.
there's nothing wrong with it, right? I mean, if it is super painful, then there could be.
Yeah, for sure.
And it's a very rare circumstance
Yeah.
that I don't think I've ever seen where someone just is doing a squat and they have a large pop and all of a sudden their knee is hurting for 3 days.
Yeah.
I've never seen that. Have you?
No.
Yeah.
I think the only thing that you will see in the rehab process, like, you're introducing things to new load, and especially the knee, and you might get a little flare up from it, and then you learn and you adjust your program. But I definitely haven't seen a severe situation where somebody just had something so insane happen, but
From doing nothing.
from doing
right?
nothing, yeah.
And those pops early on, I think those are part of the ones that scare people. Where they're
Yeah.
like, I'm just going down the stairs, my knee's
Yeah.
popping a lot more than normal.
Yeah.
And it's just your knee's going through a healing
Yeah.
process. And
Yeah.
unless you're doing a weird pivot 2 months out from surgery and you hear a pop and have pain,
Get it checked out.
Yeah, then
but
get it checked out. But
yeah.
I wouldn't worry about it, especially if it doesn't hurt. It is nothing
Yeah.
to be concerned about.
I think the biggest thing too is like people, the way that the injury happened most of them, there are some that don't, but you hear that pop, and a lot of people, like, that's just PTSD in general for a lot of people. So a lot of people are like, holy crap, like, did I pop it again? Is it totally gone? Is my ACL re-ruptured again? And I like to give comfort to a lot of people because early on after surgery, your graft is going to be the strongest it will ever be. So it really is going to have to take quite a bit for you to really mess it up. Of course, there's we need to acknowledge surgical techniques. Sometimes there's a flaw in that too. Not everything's 100% foolproof. But unless you're chasing your kids around and all of a sudden fall down a 3-5 story house or whatever it might be, you kind of have to really put some force behind it to really tear it. So pretty rare instances. Yeah.
I would say extremely rare.
Extremely rare.
Extremely.
Yeah.
Rarer than a regular ACL tear.
Yeah.
Right?
Exactly.
Yeah.
Yeah.
So pops.
Welcome
cracker
them.
Pops. Yep.
Welcome them. They're part of you, and they'll probably be with you for a long time.
No, she didn't say forever, but
Could be forever,
Yeah.
but who knows?
yeah, we're leaving that up for debate. We'll see. All right. So talking about more problems, common issues in ACL rehab. There's a ton of different things that this could be, right? You can have patellofemoral issues or kneecap-related pain. You can have a patella tendinopathy, overuse after maybe most likely having the graft from there. But the ones we're going to get into today are two of more of the major ones that require medical intervention. And these are a cyclops lesion and arthrofibrosis. Mica, you want to jump in to either one of those?
Yeah, so they happen. These things happen, and it's really hard to say who it's going to happen to, but there are some risk factors that we have seen in people with specifically cyclops lesions or arthrofibrosis. If you go into surgery and you're not well prepared, you didn't quiet down the knee, you don't have full range of motion, you had a pretty quick turnaround, or maybe even a longer turnaround of having ACL surgery, then you increase your risk for these two things, the cyclops lesion and the arthrofibrosis. But okay, so we'll tackle arthrofibrosis, I guess. Arthrofibrosis is basically scar tissue formation. A lot of people, either genetically make a lot of it really quickly and lay that scar tissue down, or because of what you looked like or the knee looked like going into surgery, then you're increasing your risk. Basically, the scar tissue blocks your range of motion. Primarily, it blocks it into flexion, but it can happen into extension or straightening the knee. And typically, it can show up as early as 6 weeks. Most often, I've seen it more towards the mid phase where we're starting to see, signs of it initially, but we're checking it up at that point, just monitoring first swelling and someone maybe not managing their load really well. But typically I see it around closer to the 12-week mark where I'm very, very certain that we're just hitting a wall. We're trying to move that range. And it's usually, can be painful for some, but usually it's just like, I'm trying so hard and it just feels like if someone were to slam me really hard, then it would go. But it just doesn't go when you hit a wall. So like that's the most common description is someone will say, I'm just hitting a wall. And then at that point, you need to go back and consult your surgeon about this. But I think the important thing is like not enough. I've worked with PTs in the past who none of them knew about a cyclops lesion, didn't know what it was, didn't know what arthrofibrosis was, and what signs and symptoms to look out for. So I think it's really important to know these things and educate yourself about these things to really make sure that you're identifying and being able to identify it early and often in those cases to really make sure that you're not having like a plateau in your rehab, so that way you can just push the needle forward. I don't know. You've seseen it?
I've seen it with I've never seen it with an ACL.
Mm-hmm.
I've seen it with a couple other knee procedures.
Yeah.
But yeah, it really does feel like it's associated with going into a surgery with a really irritated knee, right? One that is not calmed down and is going to be a very pro-inflammatory area, right? And then you have a surgery with more trauma, and inflammation is going to just run wild a little bit, right? And the way I like to think about it, and the way I kind of explain it to people, which isn't 100% accurate, but is a nice way to envision it, is if you were to skin your knee, like you fall on your knee, not surgery related at all, but skin your knee, and then you keep on skinning it over and over again. That scar is going to look way worse than if you just let it heal, right? Move your knee, don't let it pop open with the, on the skin knee, but let it heal, and it'll heal nicely. If you keep on popping it open, there's more of a chance of that scar tissue to build up.
Yeah.
And I like to think about it in that way with clients, where it's if you keep on pushing into a really aggravated knee, keep on pissing it off, your body produces more scar tissue.
For sure.
And some people, that's just their natural, their genetics, right? But I have seen it associated with people overdoing it.
For sure. Yeah.
And do you think, not to put you on the spot here, that your knee where you were at early on maybe would have been potentially moving in that direction?
Oh, 100%. I think, that I feel like in the sense of like exercise for my knee, because I really struggled a lot, obviously, with my swelling and just my range, primarily like flexion. I know we were worried about arthrofibrosis, and I don't feel like exercise-wise I was really pushing it because I had meniscus repair, so I was gentle with my flexion, but I think I don't know. It's just hard to say. We don't know. Yeah. The thing is like there was already a risk for me because I had surgery a week and a half after the injury happened. And
which is sooner than is ideal.
Yes, sooner, which, at that point, could I have waited the 2 weeks and would I have looked like a different person? Went in, I would have maybe had a little bit different scaffolding and maybe my swelling would have gone down a little bit more. I don't know, but so maybe I would have done, who knows. But I think in terms of like overdoing it, I definitely overdid. Like, if I could do it all over again, and I tell my clients this, because this is a learning lesson for me, like take the 2 weeks off from work. Don't rush. Like, this is just a really prime time to just get your crap together and really make sure that the knee settles down to a bigger extent than what I was probably going in at work. And like, I was trying my best to just stay seated and not, and keep it parallel and, elevated as much as I could. But I was going home every single night with fat toes. So it was like, I was, even no matter how hard I was trying, I still was doing it. So it's just like, well. Yeah.
So you weren't purposely pushing it too hard with the exercise, but you did. You went into surgery a little bit sooner than maybe your knee would have liked, but that was because of a meniscus blockage, right? So you did that. So you go into surgery, it's already kind of aggravated. You take a week off, and your job isn't demolishing houses, but you're on your feet, right? And so that combination, it sounds like, maybe led you to a place that could have turned into arthrofibrosis if you're not gotten taken care of. So,
for sure.
If you're 4-6 weeks out and you're hitting a block with flexion, you're feeling like you either it's super painful, too painful to keep pushing
Yeah.
through, or you just are hitting a wall and it doesn't move, like, that is a sign that you should be talking to your surgeon.
For sure. I think the other thing is too is like there are a couple factors that I think bother me a lot with other providers in like who do treat these that maybe don't see these very often is like sometimes the providers push their doing manual techniques and really push for that flexion. And I have seen multiple where you just don't touch it and you let the thing do its thing and you try to do things that's not going to further aggravate it. So it's just like, don't need to do that. The other thing is like making sure that you are doing everything in your ability are, load management techniques, right? Like, are you counting your steps? Are you elevating as much as you should? What's your range of motion? Like, how dedicated to your plan are you? If you feel like you can't confidently say that you are doing every single one of those checkpoints, then maybe try those first and really see if that changes things for a couple weeks. And if you're getting a positive sign of that, then it was probably your load management and just your program in general. But if it's just you're doing everything and nothing's working, then that's probably a good time to go talk.
Yeah.
Mm-hmm.
Yeah, totally. So we just talked on and on about arthrofibrosis. I want to make sure we do give Cyclops lesions a little bit of some time here.
Yeah.
So Cyclops lesions are going to be limits in extension.
Yeah.
Right? Limits in extension, people who also build up more scar tissue for whatever reason.
Yep.
And if you are, you remember the time frame we usually see Cyclops lesions pop up at?
Usually between like 4 to 6 months.
Okay.
Yeah.
A little later.
Yeah, a little later, and usually it's even like a little tiny wad of scar tissue that sits right in front of the ACL that wreaks havoc and creates a lot of pain and discomfort. So, but we're talking like significant extension loss. We're not talking like 1 degree, right? Where you're like, some days you fluctuate and you have like, I'm a little stiff today, but these are usually painful to go into. And there's like, you lose like 6+ degrees of motion, 10+ degrees of motion.
Kind of out of nowhere.
Out of
too.
nowhere, yeah,
Right.
out of nowhere. It's nothing that you did. It's nothing that your provider did wrong. It's just your body doing what it wants to do, and you can't really do anything about it besides go and get it removed.
Yeah. And so if you're 4 or 6 months out,
Yeah.
and all of a sudden you're like, what's going on? Why is my knee not getting straight? Maybe give it a couple days and see if you maybe did something weird and things settle down.
Yeah.
But if they don't just keep on stretching it out and trying to wait for 3, 4, 5 weeks before it loosens up again.
Yeah.
This needs to be checked out. And so if this speaks to you here and you're this far out and all of a sudden you lost motion, like don't keep on stretching it, even if your PT says we should lengthen your hamstrings.
No, it's not
Right.
the issue.
Getting with your surgeon, and it's a quick fix.
Mhm.
They don't need to redo the whole graft or
No, no, no.
anything. They just pop out that little extra bit of scar tissue, and it's a quick recovery time.
For sure, it
So-
is. Like you, typically for both of these, you're usually they encourage PT literally the next day. I've had some who maybe have had pain, but honestly, they're feeling so much better than what they were feeling before, and it's very promising. There is risk that this can happen again, but you know what to look for at that point.
Yeah. And then I think we're probably good on talking about Cyclops lesions and
Yeah, for
fibrosis.
sure.
Anything
Yeah.
else there?
No.
Yeah. So it's important that you know about those things. Your PT should, but if either of these speak to you, get them checked out.
Yeah, and if you're
Yeah.
not sure, you're welcome to reach out to us too, to see if maybe that's something that you're dealing with or are unsure about.
So we only have a couple more minutes here, but let's get into some of talking about a newer procedure. So there's over the years been different kinds of grafts that have come and gone in terms of popularity. There's been different reinforcements. There's been a bunch of different things that come and go, and some are on the periphery, right? You got the normal graft type, the traditional graft type, which is hamstring, quad, or patella tendon. Quad is now coming into the mix.
Mhm.
And we have allografts, which are going to be donor tissues from cadaver. But there's a new procedure, the Bayer procedure, it's fairly new. So there's some studies that have come out from 2015 and beyond, that were all just trials because it just became FDA approved in 2020, and it is a reinforcement of the actual graft. So I'll let Mica jump into talking about the actual graft itself.
Yeah, so, most surgeons, if they do a bear procedure, they'll hold up cute little bear. But, this is a fairly new, this has been in clinical trials for a really long time, but finally got approved, yay. But the data that we have on it right now is that we have data on people that are ranged from 18 years old to 35 years old, and promising stuff. We were seeing some decent stuff, but the issue is we're not seeing enough numbers of people having this procedure done, just because it's so new, and there's at that point in time they're still in clinical trials, so it was whether people wanted to take that risk or not. But essentially, the BEAR procedure, BEAR stands for the Bridge Enhanced ACL Anterior Cruciate Ligament Reconstruction. And basically what you have to be a right fit for this. Just because you want it doesn't mean that you're a good candidate for it. The only thing that you have to have just a pure isolated ACL tear. So if you are in that age range of 18 and 35 and just have only an ACL tear, you're a decent candidate for it. But the other issue is they look for how much of the ACL is left, and they call it a stump. So basically like a tree trunk, right? You just have that little stump, and there has to be a certain amount of it left for them to actually do something with it. And then they take some bovine tissue and create like a sponge type thing with your blood to really try to enhance and let healing and all of that stuff happen. And then they do the same drilling and stuff for the holes and whatever. But there's just a lot that go into it. The nice thing is it's not as intense as an autograft where you're taking someone's tendon. So initial early healing is actually pretty good. And it's almost like an allograft, like as somebody's donor graft, where you just don't have like that insane amount of swelling that somebody experiences if they choose their own tissue. Rehab outcomes, I think we don't have enough information on this from our end. It looks promising. They have done a couple studies on people who've gone through the process and everything, but there is promising outcomes of it, but there's just not enough people behind it for us to say it is very, very significant and really, really solid.
All the studies are small.
Yeah, they're
All
very
the studies
small.
are small. And, there's been a lot of things over the years that have kind of come and gone, and anything that limits trauma to the knee is going to look better
For sure.
early on, right? An allograft versus an autograft, right? Taking the donor tissue versus your own tissue. Taking the donor tissue, you're going to look better after 2 or 3 months than if you use your own tissue.
For sure.
And I remember, what was this, like 5-6 years ago, there was a reinforcement that was coming out, and it has since lost popularity. It still's done a bit, but and part of the benefit behind it was that, oh yeah, you're back to sport much sooner. You feel way better sooner on. You can build your strength, and there is something to that, right? It's nice to not have the early stage of rehab suck so much. Yeah, for sure. But what does the long-term outcome look like? That's really what it comes down to, right? These ACL tears are no joke. Yeah. And I mean, I would say me personally, just because there's not the long-term data, I don't think I would do it if I was a candidate. And that is just because, using my own tissue would not be fun for rehab, but at least I know what to expect. Yeah, like you have good data to support like 2 years from now, 5 years from now, you're going to have a really good outcome. And we just don't know that yet. I'm in the same boat with you. I don't think I would do it. I was not a candidate for it, even with this last one. But I think, it's thank you for the people who do participate in the clinical trials to give us this data. But for me personally, it's not worth the risk for me just to not be sure of, what's to come. And is there a potential re-rupture rate that we're unaware of right now?
And is it similar to the allograft situation? We don't know. But
Yeah, there's unknowns. You think it would be as popular if they called it the bovine graft instead of the bear?
yeah, I mean, bearish is so cute though.
It's kind of badass too. I want a bear ACL.
Yeah, I want a
Yeah.
bear ACL. Yeah, it's a
Bears don't tear-
grizzly. It's a
bears don't tear
grizzly.
ACLs,
No,
right?
they're intense. I think the thing that we need to highlight too, though, is like, there's no amount of like fast tracking your rehab process. I think regardless of whatever bear implant you decide to do, allograft, patellar tendon, everyone shouldn't, like nobody should be returning to sport before 9 months regardless. And there's no amount of fast tracking. I think everyone medically needs to be on the same page with that of saying, yeah, you're good to go at 6 months and then 3 months out you're retorn. 9 months minimum, and regardless of anything that you decide to do inside your knee, that should never change. Yeah.
I mean, this is a little bit of a side note here. I totally agree. And I wonder with the allografts and with the hamstring autografts, which both people heal a little bit quicker. They're able to load a little bit heavier earlier and they can build that strength up sooner. The return to sport timeline's a bit sooner for the hamstring graft and even quicker for the allograft.
Mm-hmm.
How much that those two graft types, which are looked at as a little riskier, how much of that would have been changed if they just had a standardized return to sport timeline.
Yeah,
so
for sure.
That's just
know.
about there.
Another thought, we can go down that rabbit hole some other day. But you're onto something with that though. Mm-hmm.
Yeah, things need time to heal, and we're getting into murky territory when we start talking about these new procedures, and until they get a bunch of people to
do
hop in these trials for free surgery, then we'll know. But in the meantime, it's not a bad choice because there is some good data.
Yeah.
And you're not messing with something that's totally unknown and is a bad decision, but be cautious there.
Yeah, I think, and just educate yourself and do whatever you feel like is best for your situation and whatever you're willing to do for your own journey. Yeah.
All right. Well, I think that's all we've got for you all, but it's been great talking. Again, I'm Dr. Sam Watkins.
Dr. Mica Riley.
And we'll be tuning in sometime in the next couple of weeks here for another frequently asked questions segment, but make sure to tune in for our other live streams where we talk about other topics that are often asked.
Yep. So. And if you have any questions or want any questions answered, go ahead and slip some questions into the feed and we'll touch base with them.
Yeah.
Yep.
All right. Okay. Good talking to y'all.
Bye.